Good morning, friends. The next module is on neonatal screening and discharge planning. The team from Amrita Institute of Medical Sciences, Kochi will cover this module. So, I am Dr. Jayashree and I will be talking on newborn screening. So, moving on to newborn screening. So, why do we need newborn screening? That's a basic question. So, we need these to detect disorders that are maybe life-threatening or those have serious long-term health consequences. And these are screened and picked up before they become really symptomatic. For example, when you consider something like a hypothyroidism, babies, hypothyroidism, congenital hypothyroidism can have serious sequelae with reference to neurodevelopmental outcome, and there can be developmental delay. And most of these babies are born asymptomatic at birth. So, by detecting this congenital hypothyroidism immediately after birth, this is just an example, by detecting these at birth, you can start or initiate the treatment in the early days. So, it has been very well shown that the early detection and treatment of congenital hypothyroidism will lead to the prevention of mental retardation. So, that is the importance of one example. That's one example of the importance of newborn screening. So, we mainly screen for critical heart disease, inborn error of metabolism, endocrine disorders, and thyroid and cystic fibrosis. And the importance is all neonates should be screened. So, moving on to screening, this can be grouped into two groups. One is the normal healthy term infants, and the second is NICU graduates who are at high risk for development of neurodevelopmental sequelae. So, moving on to healthy term infants, we mainly screen for three conditions. One is critical heart disease, second is genetic and metabolic screen, and third is a hearing screen. So, moving on to hearing screen. So, what is the importance of hearing screen? We all know that hearing is very important for the neurodevelopmental outcome as well as speech in children. So, congenital hearing loss is something which is not very uncommon. It has an incidence of around 2 to 3 per 1000 babies. So, hearing loss can lead to delayed language development, behavioral and psychosocial abnormalities, and poor achievement. So, most often it becomes delayed when the caretaker, the father or the mother, comes and says that my baby is not responding to sound, or a caretaker detects this. But by early screening, we can pick up these hearing deficits early in the neonatal period and initiate the intervention so that the babies will have a much better outcome. So, this is a anatomy picture showing the anatomy of the ear. This shows the external ear. You have the middle ear with the ossicles, and you have the inner ear with the cochlea and the semicircular canals. So, what are the hearing screens that we do in the neonatal period? OAE, or autoacoustic emission, is the one that is routinely done in all neonates with no risk factors, and this finds out how well your inner ear or cochlea works. In this, you measure the OAEs. So, what are OAE? OAEs are sounds that are given off by the inner ear when responding to a sound, and there are hair cells in the cochlea that responds to the sound by vibration. So, when you given a sound, the vibrations that are produced by the cochlea are detected by the processor, and then that is measured, and that is what OAE does. So, the procedure is you put a small earphone or a probe in your external ear. The probe that puts sound in into your ear, and it measures the sounds and comes back. The person doing the test can see the results on the monitor. It hardly takes around 1 to 2 minutes per ear in an ideal setting. So, this is a picture. You see the probe that's being placed into the external ear. OAE is very sensitive to background noise, and you need a very quiet environment, and false positive results are common in the first 3 days of life due to transient conductive hearing loss caused by the vernix and amniotic fluid in the external auditory canal. And it also requires a normal middle ear function and normal tympanic membrane mobility. So, follow-up of an abnormal OAE screen. Sometimes infants may fail an OAE screen. So, what do you do next? So, you need to repeat either an OAE or an AABR, that is automated auditory brainstem response. And if the baby fails these also, then baby has to be referred to an audiologist for further evaluation. And this repeat should be preferably done before discharge and not later than 3 months. So, OAE is done for the normal healthy term infant with no risk factors. For babies with risk factors and babies who are NICU graduates, it's preferably a BERA, that is, it's preferable to do a BERA. So, now moving on to the screening for critical congenital heart disease. So, what are the critical congenital heart disease? It refers to any heart disease needing surgery or catheter-based interventions in the first year of life. This accounts for around 25% of all congenital heart disease, which includes duct-dependent lesions in the cyanotic heart disease also. A delay in diagnosis can lead to increased mortality and morbidity. And here we use pulse oximetry screening to detect these critical heart disease. The importance is sometimes you may have a PDA dependent lesion or where when the PDA closes, the baby may present with a collapse by around 4 to 5 days. So, to prevent such situations, we prefer to do a screening at 24 hours on all babies. By this screen, we are able to detect hypoplastic left heart syndrome, pulmonary atresia, tricuspid atresia, TGA, coarctation, single ventricles, TAPVC, tetralogy of Fallot, and interrupted aortic arch. And the aim of this screening is timely identification of all critical heart disease prior to discharge from birth hospitalization. So, how do you do this? It's done after 24 hours of life. It has to be done by a trained and qualified personnel. So, oxygen saturation or SpO2 is measured in the preductal limb. Preductal limb means the right upper limb, and the postductal, that is either either foot, simultaneously or in sequence. We can either use a reusable probe or a disposable probe, and the baby should be comfortable and not crying when the probe is placed, and make sure that the proper placement of the probe is ensured. So, a positive screen means any one of the following, that is, you have an SpO2 level which is less than 90 in either extremity, or an SpO2 measurement of 90 to 94 in both upper and lower extremities on 3 measurements, each separated by 1 hour. That you are taking, that is, you are taking 3 measurements at 1 year interval, and you have a SpO2 measurement of 90 to 94, or an SpO2 difference of more than 3% between the upper and the lower extremities on 3 measurements, each separated by 1 hour. So, what do you do if the infant is positive for the screen? So, here we should exclude all the life-threatening conditions before discharge. You investigate the cause for the hypoxemia, and if once the screen is positive, you need to do a detailed echocardiography to rule out a critical heart disease. And if a critical heart disease is detected, an emergency consultation with a pediatric cardiologist is warranted. Or if that is not available, you can even consider starting prostaglandin infusion to maintain the ductal patency before the patient is referred. Now we move on to the metabolic screen. So, metabolic screen is often referred to as a blood spot testing. It's also offered to all newborns to detect a serious but potentially treatable condition. As I mentioned, this is similar to what we have mentioned in the beginning with reference to congenital hypothyroidism. So, screening is done during the birth hospitalization itself, and samples are collected for the screen before between 24 to 48 hours of life once the full feeds have been established. So, samples are collected on a filter paper from a puncture of the newborn's heel prick, and the sample is collected and put on the filter paper. It's dried and then sent to the lab. Any positive screen, this is just a screening test, and any positive screen will need a confirmatory testing. And the number of diseases tested, it may vary according to the institution. Here in our institute, we check for congenital hypothyroidism, cystic fibrosis, adrenal hyperplasia, galactosemia, hemoglobinopathies, and biotinidase deficiency. So, there should be a mechanism by which the parents can be informed of the screen once the screen comes back as positive. They need to be traced, contacted, and made them aware that the baby will need a confirmatory testing. So, next is apart from those screens mentioned, there are other two more screens which include screening for hypoglycemia and hypobilirubinemia. And regarding hypoglycemia, AAP recommends glucose monitoring for gestational babies with gestational age less than 37 weeks, LGA babies, small for gestational age, infants of gestational diabetic mothers, postterm babies who are more than 42 weeks, mothers on maternal medications like beta blockers or oral hypoglycemic agents, and babies with a family history of genetic form of hypoglycemia. In these conditions, we usually screen blood sugars by glucometer with a glucometer at 1 hour, 3 hour, 6 hour, and every 6 hourly for the next 48 to 72 hours. Next is moving on to hypobilirubinemia. This is also a preventable cause, development of preventable cause for cause of kernicterus and subsequent neurodevelopment sequelae. All babies should be assessed for the development of jaundice every 8 to 12 hours. A transcutaneous or a serum bilirubin is obtained before discharge. A pre-discharge bilirubin plus assessment of risk factors is a reliable predictor of hyperbilirubinemia. This is a risk assessment graph. Here we have the postnatal age in hours and the serum bilirubin on the y-axis. So, if a baby has a bilirubin value at 48 hours, you just plot this number on this graph and then find out under which zone this comes, like whether it's the high risk zone or the high intermediate zone and the low risk zone or the low intermediate zone. And so based on this assessment, you can decide on whether the baby can be discharged or the baby, how frequently the baby needs to be followed up for the development of hyperbilirubinemia and the next testing the next bilirubin levels. So when it becomes a high risk zone, the bilirubin should be repeated within 4 to 8 hours, and a high intermediate zone, it needs to be repeated in 8 to 12 hours, low intermediate within 48 hours, and a low risk zone within 72 hours. And these are the basic screens which we do in a term healthy neonate. And screening of the NICU graduates will be dealt with by Dr. Lakshmi. Thank you.
Hello everybody, I am Dr. Lakshmi S. Nair, Consultant Neonatologist at Amrita Institute of Medical Sciences, Cochin, and today I will be talking about screening in NICU graduates. NICU graduates are at higher risk of developing neurodevelopmental problems as compared to our normal term infants, and they require additional follow-up and screening tests as compared to our normal newborns. First, coming to the developmental surveillance. Early neurodevelopmental intervention should begin while the baby is in the NICU itself, and regular developmental screening should be performed, and it must be performed at 9 months, 18 months and 30 months of age. Preterm infants should undergo autistic specific screening at 18 and 24 months of age. Next, coming to the hearing screen. NICU graduates or preterm infants are at 7 times higher risk of developing sensory neural hearing loss or auditory neuropathy. The tests for initial screening in NICU graduates is automated auditory brainstem response. This auditory brainstem response utilizes a small chirping sound or a click which is presented at 35 decibel sound stimulus to the auditory brainstem. 3 surface electrodes are placed on the forehead, the nape and the mastoid or the shoulders, and this is used to detect some electrophysical responses from the auditory brainstem. The morphology and latency of the waveform are compared with normal neonatal templates and a pass or fail reading is generated. The test usually requires 4 to 15 minutes for screening and the baby should be asleep during the procedure. So, this is a picture showing the presentation of placement of the electrodes. Coming to the ROP screen. So, who should be screened? Infants with birth weight of less than 2000 grams and or gestational age of less than 34 weeks. Infants with gestational age of 34 to 36 plus 6 by 7 weeks or a birth weight between 1750 to 2000 grams if they have any associated risk factors. The risk factors include mechanical ventilation, prolonged oxygen therapy and any hemodynamic instability. So, when do we screen these infants? First screening is done between 2 to 3 weeks of age for infants born before 28 weeks or with a birth weight of less than 1200 grams and not later than 30 days or 4 weeks after birth for infants born between 28 to 34 weeks of gestation or born with a birth weight of less than 2000 grams. Next screening is neurosonogram. As we all know, the risk of developing intraventricular hemorrhage is highest in the first week of life. So, the first neurosonogram to rule out an intraventricular hemorrhage is done by the end of the first week. Then it is repeated at 4 weeks of age to show any evidence of periventricular leukomalacia in infants born at gestation less than 32 weeks. And it is again repeated at 36 weeks of postmenstrual age in extremely low birth weight infants. Next is screening for thyroid. This thyroid screening is done more frequently than in a normal term baby in preterm babies or extremely low birth weight babies. The thyroid screen, that is including T4 and TSH, should be obtained on day 5, 2 weeks of age and at 1 month of postnatal age. Premature babies should also be screened for osteopenia of prematurity, which includes monitoring for the alkaline phosphatase, phosphorus and calcium levels, which is done at 3 weeks of age for evidence of biochemical rickets. Preterm babies are also screened for anemia of prematurity. The iron supplementation should be started by 3 weeks of age once the baby is on full enteral feeding. Thank you.
Hello everyone. I'll be speaking on pre-discharge home equipment and also tests and procedures required for babies prior to discharge. My name is Dr. Smriti Merin. I'm one of the consultants in Ambulance Medical Science Neonatology Department. So to give an outline, first we speak on the home equipment. What are the equipment required for a baby who is going home on respiratory support? So one is oxygen, suction apparatus, amber bag with an appropriate sized mask along with a pulse oximeter or an apnea monitor. After that, I will be speaking briefly about other procedures or tests required prior to discharge. That is feeding assessment or swallowed assessment, thyroid function test, metabolic screening, then bloods like hemoglobin, reticulocyte count, hearing screens, brain imaging, ROP screens, is retinopathy of prematurity, immunizations and early intervention. So to start with home equipment. Who are the babies who actually need to go home on respiratory supports, or who are the ones who require such home equipment? Babies on nasal cannula flow, either a low flow meter or not, they require oxygen. Babies also on tracheostomy tube who are going home on the thermovent. So these babies are the ones who require oxygen, suction apparatus and pulse oximeters. Coming to oxygen, so as a nurse, what we need to make sure is that we need to give an early referral to the medical equipment store so that there is no delay in procuring the oxygen by the parents. Also, what we need to ensure is that is there a safe environment at home? That is, how are the electrical outlets? Is there any short connection or any switch anywhere which can cause a fire hazard? Also, is there adequate ventilation? How many bedrooms are there at home? Thirdly, is there anyone who was doing any cigarette smoking or tobacco smoking at home? Because they will need to stay away from our baby who is already having a respiratory illness and who is also on oxygen. And last but not least is a bedroom where the baby is placed at a safe distance from the kitchen to avoid a fire hazard since you're using oxygen at home. Coming to suction apparatuses, what we need to understand is that there are two forms. One is a bulb suction, which is very easy for the mother to use. Those who are nasal cannula will find it more preferable to use a bulb suction. Those who are having tracheostomy tubes in situ, however, they will require a suction apparatus. So the parents will also need to buy suction catheters. What our role, or as a nurse's role, is to train the parents on how to use the devices with a good hand hygiene, how to use a suction apparatus and how to use the suction catheters also. Then we come to the ambu bag and mask. Parents as such do not know much regarding ambu bag, for which we show them what an ambu bag is. We also show them how to get a good sized mask. If in case they have bought the mask, before you opening the pack, have a look and see the mask is the correct size or not so that they can replace it. So make sure there's an appropriate size of mask. How to teach them regarding attachment of a mask to the ambu bag. Ensure that the alarm limits in the pulse oximeter are set to neonatal levels because many of them come with the adult standards. And how to use a saturation probe. Many a times we have noted that the parents, they get anxious when the saturation is not being recorded correctly, mostly because the pulse oximeter probe has already become disconnected. Last but not least is resuscitation class for the parents. It would be very good to teach parents how to give a bag and mask ventilation so that if in case a situation arises when the baby is not breathing well or is having a problem with apneas or a desaturation at home, parents can immediately know to start support, that is ventilation of IPPV, that is ambu bag ventilation, while the other parent calls an ambulance. This way, you will ensure that there is less chance of deprivation of oxygen to the brain. And it has also been noted that it improves neonatal mortality, reduces parental anxiety and stress, and increases their confidence levels. Last, we come to tests and procedures that need to be done prior to discharge. Now, this includes feeding assessment of speech referral, immunizations, hearing screen, brain imaging, retinopathy prematurity screens, blood investigations, and early intervention. So, in regarding this feeding assessment of speech referrals, a baby who is closer to term with a very good weight gain, we understand that they have a better neurodevelopmental outcome. So, the babies who are at risk for inadequate growth are the ones who require high calorie nutrient requirements. So, as a nurse, a few basic questions is enough to understand the baby requires a salt referral. One, is the mother confident in feeding? Do you think there's a suck-swallow incoordination? As in, is the baby having drooling, coughing, choking, a gagging, a hoarse cry during feeds, or any reflex? Do you see a successive weight gain? And is the baby alert while feeding? If you feel there is an issue with any of these, do you think the baby requires a speech and language therapy, that is a swallow assessment? So what is a SALT assess? Basically, they assess a particular stages. Number one is sucking, that is the oromotor phase of feeding. So there are two kinds, non-nutritive and nutritive sucking. Non-nutritive is when the baby is sucking on an empty breast or on the pacifier. Nutritive sucking is when the baby is actually taking fluid from either the mother's breast. Then they assess swallowing, that is a coordinated movement after giving a bolus of fluid. So they see the movement starting from the oral cavity, going down to pharyngeal cavity, up to the upper esophagus sphincter and finally to the stomach. They also check if the aerodigestive protection is present or not, that is a coordinated movement of the nasopharynx, the oropharynx, the hypopharynx, esophagus, stomach, supraglottic, glottic and subglottic tubular airways. This is to ensure there is a safe breathing while the baby is swallowing. Then we come to immunizations. So all immunizations have to be given as per the chronological age according to the schedule of a full-term infant, and this is recommended by the American Academy of Pediatrics. So I'm going to speak about very few vaccinations that are important. First one is the hepatitis B vaccine, that is single antigen. This is based on the mother's response titers, that is she is positive if it is unknown titers to HBsAg or if she is negative. You can see the table in front of you that it's divided into preterms less than 2 kilos and also term and any preterm is 2 kg and above. You will see that if the mother for preemies less than 2 kilos, if her response or her antibody titers are positive or they are unknown, the first dose and the HB, this immunoglobulin, is given inside the NICU itself and is not counted as part of the immunization schedule. Now, if in case a mom is negative for HBsAg, then regardless of gestational age and weight, there are only 3 doses. We come to influenza vaccine, which will be given after 6 months of chronological age. You give 2 intramuscular doses of inactivated vaccine, you give them 1 month apart, and a good suggestion would be for family members to be immunized also. Now, for respiratory syncytial virus is a threat for babies or bronchopulmonary dysplasia or have been on prolonged ventilation with, like for example, congenital diaphragmatic hernia. So, for these babies, palivizumab is recommended. The CDC recommends giving them at less than 1 year of age at the start of the RSV season. And for those babies who are above a year of age, up to 23 months that is, if in case they start BPD treatment, that is in form of diuretics, nebulizations, etc. at the beginning of the RSV season, then yes, they are recommended to receive the palivizumab injection also. Then the rotavirus vaccine, which is readily available in all government facilities. Rotavirus causes severe diarrhea, vomiting, abdominal pain and fever. So the first dose is recommended to be given before 15 weeks of age and all the doses to be completed before 8 months of age. There are several vaccinations in the market. The most common ones are RotaTeq and RotaRix. RotaTeq is given at 2, 4 and 6 months. RotaRix is a 2-dose regime. Last of the vaccinations is the pneumococcal vaccine, which is again recommended for all babies with bronchopulmonary dysplasia, diaphragmatic hernias and any other cardiorespiratory illnesses. So they are recommended for the vaccination at less than 2 years of age. Usually we give Prevnar 13, that is at 2, 4 and 6 months with a booster at 12 to 15 months. Next is the brain imaging. So either a neurosonogram or an MRI should be recommended for babies who are at risk of preterm infants. It is routinely done prior to discharge or closer term gestation, whichever comes earlier. What you are ruling out in this imaging is periventricular leukomalacia or any other white matter injury. We also come to hearing screens, that is either the autoacoustic emission test or the BERA, that is brainstem evoked responses audiometry. BERA is usually done for those babies who are at risk, for example, extreme preterms, then for babies who are having prolonged ventilation stomachosis, for those who have been exposed to high doses of aminoglycoside, etc. If in case the test is abnormal, we recommend doing it again at 3 months of age. The retinopathy of prematurity. So, as per our Rashtriya Bal Swasthya Karyakram, first dose of ROP for babies who are less than 28 weeks or with a birth weight of less than 1.2 kilos, the first screen for ROP is recommended at day 14 of life, that is 2 to 3 weeks of age. If, however, they are between 28 to less than 34 weeks of gestation, they can be screened first at 1 month of age. For those who are between 34 to 36 weeks, that is if they have risk factors, for example, they have been exposed to prolonged oxygenation in the NICU, or they have family history of gene mutations like the FEBR gene. For those babies also, an ROP screen is recommended. The ROP screen needs to be done till the retina is mature and a follow-up at 1 year of age is also recommended. Last, we come to blood investigations. There is a basic metabolic screening in which you have to rule out the inborn errors of metabolism like galactosemia. It is recommended for all babies to have a test prior to discharge when they are on full feeds. Also, preterms are known to develop anemia prematurity, for which doing a hemoglobin, a hematocrit and a reticulocyte count prior to discharge will let us know whether how baby requires further iron supplementation or a proper transfusion. Then in our unit, we recommend doing thyroid function tests on day 5 at 2 weeks of age, a month and closer term gestation for extreme low birth weight babies. We also do bone labs, that is to prevent metabolic bone disease of prematurity, and we usually do them at day 21 of life and once in 3 to 4 weeks. Last but not least is the early intervention program, which is done by the neurodermal therapist. So a therapist, what they do is they address the sensory motor development, attention, self-regulation and early communication skills. This also includes parental coaching and supporting the parents for their mental well-being. So usually what she does for follow-up is that she does a Bailey scales and Darcy scales and evaluate the baby. She evaluates them at 9 months, that is she evaluates the motor, the vision, the hearing and communication. By 18 months, the fine and gross motor delays, language delays and autism spectrum disorders. The same is evaluated again at 24 months of age and also again at 30 months, that is motor, language and cognition. So from references which we have taken most of the information are from studies that are published and up to date, that is discharge planning for high-risk newborns and care of the neonatal intensive care unit graduate. Also, we have been following the guidelines from our 2018 guideline book of AIMS. A couple of informations have been taken from journals, that is the Infant Journal, then the RBSK ROP Indian pamphlet, and also from the Developmental Medical and Child Neurology, and also from standard websites like the CDC. So we hope this has given information regarding how to process of discharge, pre-discharge, regarding home equipment and also what procedures and tests, and we hope this is a useful tool for these babies. Thank you so much, and I'll be handing over to my colleague Dr. Ashwin. Thank you.
I'm Dr. Ashwin. I'm one of the consultants at Amrita Institute of Medical Sciences in the Department of Neonatology. Today, I'll be talking to you about a few aspects in discharge planning and what a nurse needs to know and what a nurse needs to check before the baby goes home. One of the major things which parents think that they know about the care given to a newborn is how to give a bath. But we must always demonstrate and also check if the parents really know how to give a bath or how to give a sponge bath to the baby. Usually we recommend giving a sponge bath as soon as the baby is hemodynamically stable in the NICU. But a proper bath is given only once the baby is more than 2 kilograms. So a lukewarm water with a regular soap, baby soap, may be adequate to give a sponge bath. Make sure the neck, groin and flexures are always clean, especially when we work in a tropical country with a lot of humidity. These are the areas which are likely to develop a lot of fungal infections. So these are the areas where we must focus and then clean these areas. And this has to be demonstrated to the parents, and then at least once the nurse needs to check whether the parents are giving the bath adequately and then appropriately before the baby goes home. Other major concern is feeding and medications. Breastfeeding, even though we think that it's simple, some mothers and even babies find it difficult to initiate breastfeeds. Most of the problems are related to nipple, a small nipple, a retracted nipple. So in case there are concerns, if a lactation consultant is available, it's always essential that a consult is taken. These issues needs to be addressed before the baby goes home, especially if you have a retracted nipple or a small nipple. Use of a nipple shield or a nipple puller or a syringe technique should be demonstrated to the parents. And then once the mother is comfortable in giving adequate breastfeeds and the physicians and the nurses demonstrate the baby is sleeping well and has a good weight gain, the baby is ready to go home. Suppose the baby is on NG feeds, again the nurse has to demonstrate how to give the feeds, how to check for pre-feed aspirates, how to insert an NG tube, and also ways they can procure all the essential stuff to provide NG tube feeding. So these things again has to be demonstrated, and then the mother has to demonstrate it back to the nurse before the baby can go home. In case the mother is very anxious as to how an NG tube should be placed, they can actually meet a local pediatrician or a local small hospital where an NG tube can be placed. However, we all encourage mothers to learn how to put an NG tube and then how to stick the tubings before the baby goes home. Preterm babies, we initiate non-nutritive sucking by 32 to 33 weeks, and once they are close to 1.5 kilograms. This again should be encouraged as soon as the baby is stable and is ready to take oral feeds well. Regarding medications, the nurse has a very important role here. She has to explain as to why these medications are given and then the exact dose that the doctor has prescribed. It has to be told to them in milligrams, and equivalent milliliter and the volume that the baby needs to be given has to be explained in detail. Specify which medicines needs to be given at a specified time. For example, a baby who is on thyroid supplements, it's ideal that we give it early in the morning. Some medications cannot be combined with others. For example, again, an iron medication cannot be combined with calcium. So the mother needs to know that these two medications have to be given separately. Again, if the baby is on medications which are in a tablet form, like thyroid supplements or hydrochlorothiazide, aldactone tablets, these tablets, the nurse has to demonstrate as to how these medication needs to be powdered and the exact quantity to be mixed and then given to the baby. Special formulas and special medications, the parents again, they need to know how to procure the medications, and then they should have adequate stock before the next review. Discharge examination. This is something, again, even though the physician does a discharge examination before the baby goes home, the nurse needs to do a detailed examination and also check whether the mother is comfortable and knows about how few important things that the mother should demonstrate back to the nurse before the baby goes home. One of the important things is a temperature check. They should have a thermometer. They should also be demonstrated as to where the temperature needs to be checked, the normal temperature ranges, and the red flag signs. Suppose the temperature is above 100 degrees consistently, they should come back and then meet the physician. They should also demonstrate, the nurse has to check whether the baby demonstrates a normal respiratory control and also has periods of regular breaths and demonstrates normal heart rate. In case there is episodes of bradycardia or apnea, this has to be intimated to the physician. It's important to establish oral feeding if the baby is stable. Once the baby is on oral feeds, again, if the baby is feeding well, has a good sleep and has a good weight gain, that has to be demonstrated. Always we plot the baby's weight onto a chart. If there is no adequate weight gain, that means there is some deviation from the physiological functions of the baby, which means that the baby may need extra investigations or may need a longer stay in the hospital before the baby can go home. So that has to be checked again. And something which we all need to understand is it's always safe to put the babies on their back or in a supine position at home. If the baby is in a prone position, they are likely to have sudden infant death syndrome. So if a baby who's more comfortable in the prone position, suppose a baby who has a Peary-Robin syndrome or a baby who has a cleft lip, cleft palate or a micrognathia, these babies are usually put in the prone position in the NICU. However, when the baby is ready to go home, they have to be put in the supine position for at least 48 to 72 hours and demonstrated that the baby actually has a good respiratory efforts, good saturation and the good blood gases before the baby can go home. In case the baby is not able to demonstrate that, these babies need to go on an apnea monitor or a saturation monitor, and the saturation needs to be checked at home. Infection control, again a very, very important aspect of care given to a newborn at home. Parents need to be trained as to how hand hygiene should be done before touching the baby. Always keep the room and surroundings clean. Cleaning and sterilization of feeding equipment is very important, especially if you are using bottles, nipples and all that. Buying a sterilizer at home is appropriate. Visitor restriction, especially in the periods of corona where you don't want a lot of visitors to visit the baby, touch the baby or cough next to the baby. It's very important that you restrict the visitors coming to meet the baby. Another thing which needs to be practiced and which has to be demonstrated to the parents is cough etiquettes. If the baby has caregivers who are facing with cold, cough or low-grade fever, they should use a mask. They should always cover their face while coughing. Always cough onto their sleeves. Use hand rub or hand wash before touching the baby again. So these things are very, very important. Another aspect of nursing care which nurses have a better role than physicians is to provide emotional support to the parents. All parents are very anxious. They may go into depression and have a lot of stress once the baby is admitted to the NICU. The medical condition of the baby itself provides a lot of stress. On top of that, medical expenses, concerns about survival and long-term outcome gives them additional stress. Postpartum depression again is very common in mothers, so that again needs a lot of support from the medical and the nursing staff. Parental mental health and self-care is important, again not just for their own health but also for the baby's overall outcome. They need to sleep well, eat, and also if they are found to have additional stress, They can be put into parent support groups. They can be provided with brochures, leaflets, websites, and also professional referral in case you think that the condition of the parents may affect the care given to the baby. So in these situations, a psychologist or a psychiatric opinion can be taken if you feel that the parents are in excessive anxiety and depression. We have always noted that once the parents are positive, once the parents are happy, the outcome to the baby is better. In case they are facing with a lot of medical expenses which they are not able to cope up with, along with the medical social worker, we can give them contacts of the charity organization which may help them cope up with their hospital bills. Discharge, again, when the discharge summary is eventually given to the parents, it is important that the nurse sits down with the family and then explain each and every step of the discharge summary, especially the medications given, the review appointments, when they need to come, which are the places they need to visit. All these things have to be explained in detail even before the baby goes home. Suppose the baby is not going to come back to the hospital because of a long distance travel or any problems related to that, they can actually go to the local pediatrician with the discharge summary, and they should have a contact with the local pediatrician, or also ideally an early intervention clinic in the local community, so that they can meet the local pediatrician there and then always get back to the primary hospital once they have additional concerns, or if their concerns are not resolved with the local place. They should be always provided with a contact number 24/7 which they can call in case they are at any distress at home. Few anticipatory guidance plans may be given. Suppose a baby who's excessively sleeping, excessively crying, or having feeding issues, the red flag signs must be explained to the parents so that they know when to seek help, and then in case they need any help, where to contact. These things should be explained in detail before the baby goes home. Suppose the parents are not able to cope up with the sick baby, or they are having any problems in soothing an infant, various options may be addressed. Again, this can be done in addition with the physician who is in charge of the baby. Always an enriched environment, a happy family, a clean environment actually helps in improving the outcome of the newborn. In short, what we have discussed today is the importance of having a very good checklist for screening all high-risk newborns and also preterm babies and NICU graduates. It's important that we have separate screening checklist for term healthy infants before they go home, and also for NICU graduates and high-risk preterm infants. A discharge plan checklist is also important. Discharge planning again should be practiced in all hospitals at least once a week. In our hospital, we have a discharge planning meet every week for all babies. Here, what we do is actually make a plan. Just after the baby is admitted, based on the clinical condition and a diagnosis is made, we make a plan as to when this baby can go home. If there is any deviation to this plan, suppose you think that the baby can go home in 4 weeks, but the baby is still with us at 6 weeks, we go back and then see what led to the delay in discharge. And this in itself is a quality improvement project which all hospitals may practice. Weekly discharge planning, like I discussed, has to be done, and then emotional support, which the nurses have a better role than the physician, is very essential. Thank you.